our speaker for tonight, Hayden Rooke-Ley, completed his JD at Stanford Law School and returned to clerk for Judge Michael McShane at the U.S. District Court of Oregon. Prior to law school, he was a healthcare policy advisor to Congressman Bill Pascrell of New Jersey, and a health policy fellow for the U.S. House Ways and Means Committee. He leads the Healthcare for Oregon Legislative Committee and continued to research and publish on issues of healthcare law and policy, including state-based single payer, Medicare privatization, private equity, and the corporatization of medicine. And we will see some of his slides pretty soon and put in the chat reference links to his articles on these topics. So one little bit of information is he was the nation's leading free thrower in basketball in 2014, and used his skills to relieve tension. I guess he probably still does that. So Hayden, you're on.
Always doing that to me, Mike. I appreciate it, though. I'm going to go ahead and share. I think we're good here. So thanks everybody for having me. It's fun to be here with fellow single payer advocates. I'm going to give a presentation that I and a number of colleagues gave to the Oregon State Legislature.
I think everybody knows that Corvallis is the epicenter of corporate activity right now, and that's one of the topics that we may get to talk about. We're concerned about the patients in our area, but also the clinic itself. It's been a treasure for our area, and we want to keep these doctors and the staff and the clinic here. We don't want it taken over by Wall Street.
How many clinics do you have there?
I think I saw 11 or so, and about 100 doctors.
Yeah. You've got one out in Lebanon, right?
Well, Samaritan does. Maybe the clinic does as well. I don't know.
Okay. I think we have an urgent care out there.
Yeah.
Oh, okay.
Yeah.
Okay.
As I was saying, I'm going to give an abbreviated version of the talk that I and a few colleagues gave a few months back to the Oregon State Legislature, generally on the topic of healthcare corporatization or healthcare consolidation, healthcare financialization, these terms that folks are using today to sort of describe what is a real transformation in the ownership landscape of our healthcare system. And this hopefully, and I think will be familiar to many of you. So I think just to level set here, and again, apologies if this is redundant for healthcare advocates who are familiar with the system. But we've really seen over the last number of decades, beginning in the 1980s, a real sea change in the ownership landscape of physicians. If you go back to 1980, I think around 75% of physicians own their practices, and today it's the reverse. About 75% of physicians are owned by some corporate entity, whether it's a hospital or whether it's these emerging sort of non-hospital corporate entities, namely private equity, insurance companies, and big pharmacy retailers. So as you can see on the bottom of this slide here, the numbers as of the beginning of 2022, number was almost 74%. This data is actually hard to track today. It's surely higher, but we're actually not totally sure where that number is as of now. So the bulk of this corporate ownership is driven by and continues to be driven by hospitals. We're all familiar with large hospital systems that have grown in our communities. As I'll talk about in a second, the recent growth is being driven by non-hospital corporate entities, but it's important to note that hospitals continue to be the largest employer of physicians. And what we've really seen, and that number's at about 51% now. And what we've really seen over the last, again, this time period really sort of beginning in the 80s with the managed care movement and the general trend to sort of shifting power in our healthcare system away from physicians and patients and towards various sort of corporate managers and big finance. We've seen from the hospital perspective, both what's called vertical and horizontal consolidation. This slide really depicts sort of the exception to the rule, actually noting the few mergers from 2007 that have been held up by federal regulators, which again is really an exception to the larger rule that from a hospital to hospital merger perspective, and that's what we refer to as vertical or horizontal consolidation. Courts and regulators have really been lax in terms of stopping hospitals from merging with each other and accreting the type of market power that we see really in every single community we look in the States. The briefly sort of the consequences of this horizontal consolidation is there are many, but the main one that we see in the literature is increased prices on the in the commercial market. So it's a pretty sort of intuitive story where hospitals have gotten bigger. They've consolidated, as I said, with each other. They've also consolidated with vertically with other physicians. So think about a hospital buying a local physician practice to really, become these large hospital systems that have dominant negotiating leverage when it comes to negotiating with insurers. So what we've seen is sort of notoriously high prices in the United States in the commercial market where they can be negotiated as opposed to Medicare, where we see where prices are fixed. Another consequence that we've seen is growing monopsony power. So this is the ability for hospitals to negotiate with their suppliers and principally with their labor. So literature shows that stronger market concentration of a hospital leads to lower growth in nurses' wages. And then the third sort of consequence we've seen of hospital consolidation is ways to sort of manipulate the Medicare payment system. The ones that are typically pointed to are the ability to gain higher payment rates when a hospital is technically an outpatient provider. So if they purchase a local physician practice and can be designated as a hospital outpatient department, they're able to bill for higher rates with Medicare. And then we've also seen manipulation around the 340B program, which is the drug purchasing program, has given hospitals a strategic impetus to purchase providers and get discounts on the way their drugs are paid for. So the general story here is that consolidation, for all its promises of sort of care integration and efficiency, really has, the primary effect of this of the consolidation has been really higher costs without better quality. And these are, three of the ways that we've seen that manifest. So that's sort of the hospital story. The potentially more interesting story is the corporatization we're seeing of late by non-hospital corporate entities. And that's what I referred to earlier as principally private equity, insurance companies, and big pharmacy retailers. And this is where we're actually seeing the most acceleration in corporate ownership. We've got a largely Oregon crowd here, which will be familiar with recent acquisitions in the state by large insurance companies. This is a trend we're seeing nationally where quite rapidly these non-hospital corporate entities are acquiring positions really at warp speed. And this is the sort of other 25% and growing that we see that amounts to the total of 75% corporate ownership of physicians. I'll touch briefly on each of these and try to get through all this quickly to get to questions. I don't want to bore you guys with too many details. To take private equity first, this is just a slide showing the degree to which private equity, so a form of private finance investment, has really increased over the last few decades. Private equity investment, there are a number of ways to show this, but in 2000, for example, it was $5 billion. In 2018, it was $100 billion. So the amount of private capital from financial investors in the healthcare system has really grown to a staggering degree alongside the growth in corporate ownership of physicians. I'm not going to get into too many details of sort of the business model here of private equity, but the upshot here is that similar to the sort of games we've seen played in the hospital setting, we've seen private equity owners do the same around sort of abusing market power. So one of the canonical strategies of private equity investors are to really quote unquote roll up a group of a certain specialty in a market, and develop that market power, so then they can negotiate rates with insurers, driving up prices. This is what we're seeing challenged right now by the FTC, actually, against U.S. anesthesiology partners, a lawsuit they recently brought, not only bringing the case against the sort of paper owner, which is U.S. anesthesiology partners, but also the major private equity investor who's driving the strategy behind all of this. This slide just shows, again, some of the consequences of private equity investment. There's been studies just keep coming out more and more showing some of the dangers here. The upshot is really increased prices, increased utilization, and really not much better quality. I'm going to skip that slide. So we talked briefly about private equity. The other two big players we're seeing now are insurance companies and big pharmacy retailers. And a big driver of that right now are some changes that we're seeing within the Medicare program. Many of you are probably familiar with the degree to which Medicare is privatizing, particularly over the last decade. This is primarily being driven by Medicare Advantage, which is the private version of Medicare, and now constitutes over half of the Medicare program. This is really another sort of another one of these sea changes of the last 1 or 2 decades. Really has transformed the way Medicare looks. You know, I think in 2000 it was probably around 10–15%. Medicare Advantage, as I said, is now over 50%. We've also seen in the last decade a real transformation in the way that a traditional Medicare is financed. You know, through accountable care organizations, direct contracting, and a bunch of other sort of capitation-based models. We're really seeing the financing of Medicare look more and more like Medicare Advantage, and this creates a whole bunch of incentives for Medicare Advantage insurance companies to actually own providers, and that's exactly what we're seeing all across the country. So just a few examples to you know, make this familiar for folks. United Healthcare is the biggest player here. Again, we've got a lot of Oregon people here, so folks may be familiar with the recent proposed acquisition. Oh gosh, the recent proposed acquisition of Corvallis Clinic by Optum, which is United Healthcare's subsidiary. United Healthcare is now the owner, it says, of 90,000 physicians nationally, actually the largest employer of physicians in the country. So what you're seeing is that the big insurance companies like United, particularly Medicare Advantage insurance companies, purchasing physicians and then also rolling up the drug supply chain. So United is also one of the owner of one of the 3 biggest PBMs, pharmacy benefit managers, and also works closely with pharmacies. They own sort of online pharmacies, but also work closely with retail pharmacies like Walmart, to really sort of create this triad of vertical consolidation between the insurance company, the primary care provider, and the drug distributors and pharmacies. We're seeing the same roll-up strategy with CVS Health, which is now owns Aetna, another large Medicare Advantage company. CVS, you all know, is pharmacies. They purchased Aetna in 2018. Aetna is now, or CVS is now aggressively purchasing primary care providers and then home care providers. And this is really the target of these physician acquisitions from Medicare Advantage insurance companies, is really not the facility setting. So not hospitals, not facility-based post-acute care, but really primary care, both brick and mortar and in the home, and then home-based post-acute care. And this, again, creates a whole bunch of synergies from a financial perspective for them that we worry about from a competitive and sort of public policy perspective, but it's a really lucrative financial model that, you know, we can talk about it further if folks want to. Just a third example is the same sort of game we're seeing between Walgreens, Cigna, and Village MD. Village MD is actually has a decent amount of presence in Oregon. They recently acquired Summit Health, which is another group of large national chain of primary care providers. They are Walgreens is a majority owner, and then Cigna, another commercial and Medicare Advantage insurance company, is a minority owner in Village MD. So again, just to illustrate the type of vertical consolidation we're seeing happening right now. And then Amazon is the last one. They've yet to get into the insurance business, but similar consolidation strategy with their purchase of One Medical. One Medical had actually acquired Iora Health, which is a quite notable because that's another one of these Medicare Advantage focused primary care offices or primary care chains, which is what certainly was quite attractive to Amazon. Again, illustrating the amount of business that Medicare Advantage is driving, and the amount of ownership of providers that it's driving. Okay, I'm going to talk quickly just about a couple solutions to or a couple things that at the state level that we can do to start to combat some of this. Mike, how am I doing on timing? I could talk a little bit about CPOM. I could take questions. You're muted there.
Mike, you're on mute.
Yeah, go ahead. Thanks. 10 minutes would be good.
Okay, great. So one solution to try to address some of this corporate consolidation is for states to try to sort of revitalize and a bit reformulate their bans on the corporate practice of medicine. This may or may not be familiar as sort of a legacy doctrine for folks, but really there's an interesting history to what is the ban or was the ban on corporate practice of medicine. States have actually had some version of these bans dating back to the 1800s. And the idea really was quite intuitive up until, again, this sort of period in the 1980s when sort of collectively as policymakers, we decided that commercializing the industry, commercializing medicine was going to be sort of an advantage. It was going to bring managerial acumen. It was going to bring efficiency. But up until then, there was a real understanding that there's a conflict between business and healthcare, that healthcare is sort of fundamentally meant to be in the public interest. Business obviously is primarily interested in pursuing profits. So regulators have for centuries recognized that there's a conflict here and really have tried to create a dividing line between being engaged in the practice of medicine and operating a business. So what we've seen is mostly at the state level through sort of a patchwork of regulatory bodies, whether it's state courts, state attorneys generals, medical boards, and then in statute, laws were passed to create this division between practicing medicine and engaging in business. And really what these laws tended to say is that if you're a lay corporation, you can't own or control the provision of medical care. And I don't know if Mike attached our recent work on this, but this graphic here and a lot of what I'm sharing is pulled from some work that colleagues and I have done in the last year on sort of documenting the corporate practice of medicine ban over across the country. What we've really seen since the 70s and 80s is these bans being relaxed really all across the country in different states. And there are a couple of ways this has been done. I'll try not to get too technical here. One is what we've seen in Oregon, where in statute, typically the way that the corporate practice of medicine ban was expressed is that if you want to own a physician practice, you've got to be owned by at least the majority, sometimes exclusively, licensed medical providers. And what we've seen over the decades is that those laws have been relaxed to allow certain corporate forms in Oregon, for example, LLCs and LLPs can engage in the practice of medicine without having a majority provider ownership requirement. We've also seen exemptions for certain types of providers. HMOs is sort of what launched all this. So during the HMO movement, the thinking being, again, that moving power in the healthcare system to managed care organizations was going to help bring efficiency and improve quality. These bans got relaxed actually through both federal regulations and sort of dictating to the states to create exemptions for HMOs. And then we've seen hospitals to be typically exempted from corporate practice of medicine bans. And then the third way we've seen sort of an erosion of the doctrine is probably the most pernicious. And this is essentially private corporate owners have figured out ways to contract around the doctrine, sort of irrespective of how strong the nominal law is on the books in a given state. And this is what we talk about in the piece, that even in states like California or Texas, which do have strong prohibitions on the corporate practice of medicine. What we've really seen is that corporate owners, whether it's private equity investors, whether it's the Optums of the world, retailers, certainly hospitals too. Its intent was to prohibit them from owning providers. They found ways to essentially contract around the doctrine, and this is where legislative solutions get interesting, because you have to really get into the details of what we mean by sort of protecting ownership within physicians. But essentially through this friendly PC structure, which is taken from the private equity industry, these corporate or lay owners have figured out ways to essentially contract with physician-led practices without actually legally owning them. And this is what, from a regulatory perspective, makes this problem a bit of a challenge, because you have to get really sort of detailed and specific in terms of what you want to ban. If the intent of the legislature is to stop, or at least to slow down the level of corporate, really functional corporate ownership in a given state. And I'm happy to get into details of this again if there are further questions. Skip over, I touched on kind of what the lay of the land is in Oregon. I'll just make one last point here, actually two last points. One, enforcement is another area where we've really seen a relaxation of the corporate practice of medicine ban. Oregon's a good example of this. In the state today, I mentioned earlier that certain corporate forms don't have to be owned specifically by licensed medical providers, but if you want to be a professional corporation, a PC in particular, you need to be majority provider owned. However, the state, there's no enforcement or even monitoring of this, and this is consistent with what you see across many states, is that here in Oregon, for example, we have no idea whether professional corporations, so that specific corporate form that does need majority physician ownership, we actually have no idea whether PCs are actually complying with this. So this is another sort of way that the doctrine's been eroded, just states really just not enforcing what does exist in their corporate practice of medicine ban. So that's just one way to sort of address this problem. I'll highlight one other that folks are familiar with here in Oregon. And this is states are increasingly passing legislation to establish their own regulatory bodies that are sort of a version of the FTC or the DOJ, but at the state level. Here in Oregon, we have what's thought to be the strongest one. So this is an agency that has the statutory authority to block mergers and acquisitions if they harm not just competition concerns, but actually concerns around affordability, accessibility, equity. So this is a novel kind of movement we're seeing. I think Oregon, along with 5 or 6 other states, have bodies like this. Really nascent stages right now, and a lot of national eyes are on states like ours to see if they're actually going to do anything. Currently, Oregon's reviewed, I think, 18 transactions, but hasn't actually blocked any of them yet. And they're also under the hospital lobby right now is challenging the constitutional validity of the regulatory body in and of itself. So it's a really interesting time in terms of whether these bodies are going to actually do anything to slow down corporatization, and whether they're going to survive as constitutional sort of writ large. And so I think this is really an interesting area for that a lot of people are watching, as at the very least these transactions get reviewed. But to date, at least specifically here in Oregon, no sort of big transaction has been held up. So that's another, Mike wanted me to kind of touch on things at the state level that can be done to try to address some of these issues. Happy to talk about some other ones, but I'll leave it there for now.
Thank you so much, Hayden. We're open for questions now. And anybody have questions for Hayden?
Yeah, this is Lei. Can I have a question?
Certainly.
Yeah, this is very basic and probably simplistic, but what is meant by saying that providers or physicians are, quote, being owned by corporation and private entity, being owned? What exactly does that mean? Are the doctors being salaried through by the corporation, or they still fee for service? I'm a retired physician, so I don't know how things are practiced anymore. But beyond recruiting members through insurance and telling you can do this, you can do that, you can appeal and so on, how much of being quote owned by the corporation actually affect the clinical practice of the physician?
Yeah, no, that's actually a terrific question. There are a couple different answers to it. One, in terms of what we mean by ownership, this is actually a complicated question because let's say, take a hospital who employs physicians, that's pretty straightforward. And I refer to these terms kind of colloquially. When I say a hospital owns, a provider, what I mean is, a physician is just an employee of the hospital. What I was referencing with private equity and some of these other non-hospital corporate owners, they actually legally don't employ the physicians. They contract with a professional corporation that's owned by physicians through their own subsidiary. So let's say Optum or a private equity company has a management services organization, and they'll contract with a professional corporation in a way that essentially allows them to exert functional control over how the practice is run. This is what we're seeing in the proposed merger, proposed acquisition of Corvallis Clinic. Optum is installing a single physician who's a licensed physician in the state as the sole owner of the professional corporations. So they're going to, this person that's been identified is going to employ all the physicians at Corvallis Clinic. And then they're going to contract in a management services arrangement with Optum. And Optum is basically delegate everything that's not, in this specific transaction, everything that's not a clinical judgment. And the concern here is that when the corporate owner essentially is in control of everything but sort of a contract that says, we don't make medical decisions, this is when we start to talk about the corporate owner, for example, making all the decisions around who gets hired and fired, or they might have a non-competes, or they might have gag clauses, or they often will have control all the advertising of the practice, or even in many cases actually having what's called a stock restriction agreement, where the owners of the practice have to get approval from the management services organization, the lay corporate owner, when they want to sell their shares. So all these contracting provisions that essentially amount to control by the corporate owner of the medical practice. In California, we're actually seeing a federal lawsuit right now challenging this contracting model by a plaintiff bringing a case against a private equity owner in the context of emergency medicine, basically saying the way that they're entering in this contract undermines the spirit of actual physician ownership. So I hope that made some sort of sense. This gets technical very, very quickly.
So do you think indirectly physicians' clinical decision will be affected?
Yeah, I mean, this is sort of the big question that all of this is quite new and hard to quantify at this point. I think people have an intuitive sense that corporate owners are more in control of of sort of the practice of medicine than they ever have before. And I think you can point to, I don't think it's a coincidence that we're seeing such moral injury, such burnout within the medical profession, and the degree to which, corporate interests are sort of making the decisions at the highest level. One example that I noted the other day in a New York Times article on physician unionization at Alina Health System. The quote they had from the physician was, Alina Health System is an accountable care organization. They also have a Medicare Advantage insurance company. And what the physician said was that he's paid on the basis of how much he documents risk diagnoses for his patients. And he said that when I'm paid I have a 25-minute visit with my patients, and I'm paid on the basis of how many diagnoses I can go through, that actually has nothing to do with the clinical value of the visit. And this undermines, patient care. And it also undermines his, I think, commitment to the profession and, the value he sees in practicing. So it's a fair question. There are counter arguments to this that, having corporate investment and corporate ownership is a good thing. I personally am skeptical of this, but you can find folks who would say that physicians today, they don't want to be in control of their practice at all. They just want to be employees. But I don't think the trends of physician sort of demoralization, I think don't suggest that this is a sort of healthy path for the profession.
Thank you.
Of course. Patty?
Yes, Hayden, thank you for that presentation. That was certainly, excuse me, certainly damning evidence, basically really incontrovertible evidence of how private equity and corporate powers are taking over medical practices. And I just wonder, what were the circumstances around which you made that presentation to the Oregon legislature? And how was it received? And was there media attention? There was any really concrete results that we could look at as a result of that presentation?
Yeah, there's been a little bit of media attention. So there's a effort right now in the state legislature for this short session that's going to begin in a few weeks to strengthen Oregon's corporate practice of medicine ban. So there's going to be, we were talking about the issue generally, and then specifically, we are advising a state legislator to update the corporate practice of medicine ban in Oregon. That legislation is about to get released, and hopefully there's going to be a lot more press coverage around it. We've been working closely with legislative counsel to try to get the language right, but there's going to be an attempt, at the very least, an attempt here in the next few weeks to try to update Oregon's corporate practice of medicine ban to start to try to address some of these issues here in this state.
So the queue actually starts on the left, Hayden. So next would be Lou.
Lou.
Hey, thank you. So, I come from a union background, and what I've noticed is that as doctors become more employees, they are unionizing. But my major question is, are unions aware of the effect that this corporatization of the medical industry will have on their jobs and their ability to negotiate? You see, there's a lot of unions involved with Medicare. It's ONA, of course, but SEIU, ONOHP, many of them are involved. And there's a tendency for a union to be short-sighted in that, oh, well, I don't care, I still got a job and it's paying good, right? But so have you got any idea of the effects or any research on the workers that work in the clinics and hospitals and whatnot that are being corporatized? That's my question.
Yeah. So there is some research on this. What I briefly touched on earlier in the hospital setting, you do see nationally where hospitals are more consolidated, they have, a greater ability to suppress the wages of their nurses. And I'm sure you would see similar evidence for other care workers. So that's what we see nationally. Each market is different. Oregon is we're going to see here with this big merger in Portland, how the unions play it. I think there are, as far as I understand so far, the unions aren't opposed to this legacy OHSU merger, which would be the largest hospital merger in Oregon history. I'm actually as curious as you are to see sort of what their reasoning is. I'm sure they have ones and good ones. It could just be about the sort of idiosyncratic relationships between legacy and OHSU.
Yeah.
I think unions tend to be quite aware of large corporate interests, and particularly with hospitals, because they tend to be the largest employers. I think the big question for unions, and where we see the most variation, is kind of what you pointed at, Lou, which is that some unions kind of remain fixated on their kind of parochial interests of sort of the next contract and negotiating the next deal. Other unions, for example, when I was in California the last 3 years, the nurses down there, I think really have raised their gaze and really understand that for the best interests of their nurses and of their communities, that moving past the model we have right now, which is such an antagonistic model, such a profit-driven model where hospitals, you know, where nurses are really just a line item for hospitals, you know, that system's not going away unless we transform things. And that's why they're so vocal about getting to single payer and trying to move towards a system that runs on a different logic. And that's where, you know, I would love to see more and more of the unions in the healthcare workforce move towards.
Thank you.
Okay, Rick.
Yeah, first I just want to point out that
You have to get closer to your mic, Rick.
it's up here. Can you hear me
That's
now?
a little better. Yeah.
Okay. Well, anyway, first I want to point out that Senator Gelser-Boyne's aide asked whether the presentation was in the House or the Senate.
Louder.
Yeah, I answered that question in the chat, Rick.
Okay. I didn't see that. Just wanted to make sure it was answered for. Okay. The the question I had is, let's say the Corvallis Clinic was mismanaged, and so they were really hurting, and they maybe are in danger of bankruptcy. What happens if we stop this sale? What happens to the employees? What happens to the clinic?
Good question.
I guess that's my question.
Good question.
Yeah. I mean, I think this sort of, you know, hypothetical comes up with a lot of the transactions that we see in the healthcare setting. So anytime there's a big hospital merger, you're going to get the same defense. Or anytime, you know, you see consolidation of, you know, drug supply chains, or even of companies. You know, we're dealing with this right now with the CCOs, with Care Oregon saying, you know, we're not going to survive if we don't merge with a bigger entity. So I think this is actually where single payer advocates are in an incredibly strong position, because you're exactly right that we have to offer an affirmative vision here. What's the alternative that's gonna build a system where, you know, each physician practice isn't in such a difficult position where they want to sell to a financial investor. You know, we have all sorts of laws across the economy that might be, you know, mutually entered into, that might be beneficial in a, you know, transaction to transaction sense, but that we prohibit, you know, like easy examples like child labor or something like that. What corporate practice of medicine says is that there are certain things, certain types of transactions, certain owners that we feel shouldn't be engaged in actually owning and running a practice. So if they want to be part of this, they need to be a truly an ancillary sort of vendor. And Optum and other private equity owners can do this if they want to, you know, provide capital, but not assert this sort of ownership that we're concerned about. That's still allowed. And then we just get to this bigger question of, are there certain types of ownership that we don't feel comfortable with as a rule and as policymakers that we want to pass? So I think as single payer advocates, we then are in a good position to answer the question of like, well, here's a different model that we should be working towards. The answer to, you know, the difficulty of primary care physicians not being able to survive right now, the answer isn't sell to a private equity company. The answer is let's publicly finance a system so we have the ability to actually move capital around publicly where it needs to go, i.e. primary care, and create a resilient infrastructure of primary care, of acute hospitals, and perhaps all other types of providers that's resilient to, you know, financiers and other sorts of corporate owners that see a financial investment.
I totally hear you, but that doesn't really answer my question, because in this case, I think it's true that they're in serious financial problems.
Oh no, I don't doubt that at all, Rick.
So what happens?
If what?
Well, you said this is how we talk about it, and maybe it's not really true, but I think it is true. Let's just assume it is. So what's going to happen to Corvallis Clinic specifically?
Yeah. So one, first of all, you know, no legislation has been passed in Oregon to prohibit this. So what specifically the legislation in Oregon would actually do wouldn't prohibit some type of capital investment. It would just have stronger guardrails around the level of control and ownership that a corporate investor could take in the practice. So it's possible that you would still see Optum interested in being a vendor to Corvallis Clinic, or you might see another investor be interested in being a vendor to Corvallis Clinic.
Just maybe I'm the one, maybe I'm confused here. but I'm talking about the agency that reviews these deals. That's already in place. You're talking about legislation that we could consider, right? Am I understanding
Yeah.
you? So what about the way things are right now? If that agency reviews it, which they're doing, I think.
Yeah.
What happens if they deny it? That's really my question.
So then they have the authority to deny it. So the acquisition wouldn't go through as it's proposed. So maybe they come back with a different proposal, or go to a different vendor. I couldn't tell you what happens, but the HCMO, Healthcare Market Oversight body, has the authority to block this.
Okay, so bankruptcy is a possibility as a result.
Yeah,
If
I
they can't
couldn't
get the
speculate about
finance.
Corvallis Clinic. Yeah, about what they would do in that contingency.
Okay, thank you.
Sure.
Mary,
Good question.
Mary,
Do
yeah,
you
go
mean
ahead.
Mary Sharon?
Yeah,
Okay,
Mary
good. Yeah, good. Thanks, Hayden, for your comments. And I sort of get my education on this whole issue through the American Prospect. So you're really affirming a lot of things that are being said. So my question is, do you have a sense of what's happening with Peace Health Medical in the Springfield, Eugene area?
Good
It
question.
seems to be a nonprofit system that operates on a for-profit model, which makes me nervous. Is it attractive for profit-driven purchase right now, especially since they pulled out of Eugene entirely and are only in Springfield?
Yeah, I should have made this clear when I spoke about hospitals earlier. I don't think this is true actually for everything in healthcare, but hospitals specifically. There really doesn't appear to be much distinction between the nonprofit and the for-profit designation in terms of how these, they're all certain types of corporations in terms of how they behave. So I think for Peace Health, the question is less, are they going to sell to a big corporate, for-profit hospital chain? That's here now. I think we've seen through, a lot of the behaviors that Peace Health is engaged in. I think I don't think this is particularly controversial. They operate on a given model that is expansionist. They're trying to drive a margin. They're trying to grow, and they're operating within the system we set up, which gives them all sorts of incentives, again, to basically try to drive as much revenue with each admission and keep their costs as low as you can. I think what a lot of single payer advocates want to do is move to a more sort of utility type model where we treat healthcare providers more like we sort of treat utilities, in terms of the degree to which we regulate how they spend money, where they spend money. But right now, a nonprofit hospital system, in terms of its operations, really isn't looking much different than a for-profit.
Charlie.
Yeah, so this is related to some of the things you said, not directly to a lot of the other things, but you've mentioned a bunch about a lot of these bad things that are happening are related to the expansion of Medicare Advantage. And one of the things that happens pretty much every year is that Congress writes a letter about Medicare Advantage to CMS. And very soon they will probably write such a letter. Last year, there was Jayapal put together a letter that was not quite so positive about Medicare Advantage as what happens normally. And there was also a very, very strong pro Medicare Advantage letter. So it seems like it might be worthwhile for people around the country to push their legislators or members of Congress to sign on to a decently worded Medicare Advantage letter, something like what Jayapal wrote last year. And so just sort of a suggestion of a way to get at one of the pieces of the problem.
Yeah, totally agree. And I know there are efforts to try to block that letter again or get fewer signatories. I do think part of the story that's less told is the one I tried to tell here, which is the way that Medicare Advantage is driving corporate ownership of practices. There's a lot of sort of reporting and a lot of coverage of the way that these companies are denying coverage to patients. For example, with NavaHealth has been in the news recently, which is a quote unquote convener that United bought, and it basically exists to get people out of the skilled nursing homes, and it uses algorithms to do this, to basically predict how long they get to stay and then get to be released. There's a whole bigger story around NaviHealth and why Optum bought it as a subsidiary of of United Health Group. And this really has to do with Optum's or United's attempt to consolidate, not just be the insurer, but be the owner of non-facility based post-acute care. So home health that I was referring to, and then also these conveners, all big insurers have them. NaviHealth is just one, to again, basically take patients, keep them out of a skilled nursing home, because that's where sometimes patients want to be out of there, but it costs more. And basically the larger strategy is to keep patients, is to move patients to their sort of other subsidiaries. And then it's sort of a win-win for an insurance company that also owns the home health providers, because they basically, quote unquote, win both sides of the transaction. So the larger point here is that I think there could be a lot more awareness around the degree to which Medicare Advantage is not just costing taxpayers, to the tune of arguably 150 billion a year, but is also denying care to patients, but then also really basically giving insurance companies the capital, public money directly, because it's so oversubsidized, to go and buy providers. And then you see this sort of closed network, patient steering that is becoming all too familiar.
I'm coming with Charlotte.
My question is going back to the possible bill that will be before the legislative short session. When the language is confirmed, will it be something that we can look to, those of you involved in confirming that or finalizing the language, to put the word out through, Healthcare for All Oregon and, and other networks, so that we can jump on it right away?
Yes, absolutely. You will be hearing from us. We're just waiting to get the bill finalized and actually out, and then we're going to try to rally as many constituents to get on the legislators to support this. So absolutely.
Who's the co-sponsors at this point?
So on the House side, it's going to be Representative Ben Bowman, and then I'm not sure of this. I'm not sure if I know we've got the support of Deb Patterson, who runs the healthcare committee on the Senate side. I'm not sure how the co-sponsorships work and stuff, but I think the plan is to have her lead efforts on that side.
Thank you. Thank you.
Of course.
Oh, Mary Beth. Sorry.
Mute?
Yeah. Go ahead. Unmute, Mary Beth. I'm sorry. I clicked too
I
soon.
thought I was really unmuted.
Yeah.
Sorry about that.
Sorry. Yeah.
I don't really have a question, but I do want to draw your attention, Hayden, just to a couple of things in the chat. So Wes is saying, as we think about profit versus nonprofit, that nonprofits are the answer, but it seems that that same thing that you were saying, they're not the solution, because they go in that same framework. So is there more that can be done around, and Wes, if I'm misspeaking, tell me, but that could be done maybe to strengthen the rules around nonprofits and for-profits?
Yeah, definitely. This is kind of what I was flicking at, Wes, when I was talking about kind of what I think of as more of a public utility model. So I do think nonprofits are the answer, but a different sort of form than we see now. For example, I think the vision that really all the single payer bills start to sketch out, albeit not with too much detail, but really is a model where to take hospitals as an example, they're funded on sort of on a budgetary basis, really similar to the way a number of Canadian provinces fund their hospitals, and they operate on quarterly or annual budgets, and there are much more constraints around how much they're spending on CEO pay, on administrative costs, and on basically capital expansion. And this is a big one. So I think that the vision of single payer that I personally support, and that I know a lot of proponents do, is really separating out a hospital's interest in capital investments and expanding and getting bigger and bigger from their operations. So hospitals would be funded with the money that they need to take care of patients, but there would be a lot more regulations around how much they could take that money to really drive a margin to then build and expand. And this is really the source of sort of the profit-driven model that leads to such suppression of workers, of wages of the care workers, of exploitation of patients, and again, of these sort of behaviors where we see nonprofit hospitals really acting like for-profit entities. But if you had a world in which there were no incentives for them to drive a margin and make capital investments, pay their CEOs, and importantly, not to waste so much administrative cost billing and coding all the time, dealing with insurance companies, you really free up a lot of money for actual care, for the money to go to patients and their caretakers, which is where much more of the money needs to go rather than all these other areas. So I do think they would be nonprofits, but not the type of nonprofits that we see, in I won't name names, any given health system.
Sharon Schmidt,
You're muted.
still muted.
Sharon Schmidt from Minnesota. And you mentioned something about the 340B discount. And last year we had a bill that was trying to get the Medicaid people or patients from being able to choose the state instead of the MCOs if they chose to. And we almost got that bill through, but at the last minute, a hospital came in and said, oh, if that happens, we're going to lose the 340B discount and we will lose money. Do you happen to know, and I'm not an expert in this area, we have lawyers and financial people that are working on that, but do you happen to know the rules or the laws around that maybe I could send you an email with questions, because they're telling us one thing and our people are saying there is no such law, that they have to go through MCOs to get this 340B discount?
Interesting. I won't claim to be an expert. I'd be happy to look at any email and see if I can be helpful. Generally, it's not surprising to hear that this is incredibly important for hospitals. Program
And
allows
clinics and others.
Whoop.
Yeah, you were muted for just a second. You're back.
Yeah, so I was just saying, essentially, the program allows hospitals that have the designation, so serve a certain, I think, percentage of low-income patients. It basically allows them to purchase drugs at a much lower rate and then sell them at the same price. So it's a huge margin generator for hospitals. Really good intent of the legislation. Again, I'm no expert in it. I just know that it creates a really strong incentives for hospitals to sort of strategically get bigger to meet that threshold. And we've seen just a proliferation of 340B qualifying hospitals in a way that doesn't sort of track with where low income folks have moved or something. It's clearly a financial move. So
Yeah.
happy to try to help if I can, Sharon.
Okay, all right, thanks.
Pamela,
Oh, thank you. I have two things I want to say. First of all, about nonprofits being on the same track as the private equity and all that, the for-profit. And there's one huge difference that I'm not hearing that we're talking about, which is that a nonprofit designation means that they have to give back to the community instead of keeping their excess, which is what they call, what a profit organization would call profits. And that seems like a point that can't be underemphasized. It's simply because it's so crucial. We actually have power in this discussion if we leverage that that understanding and make it something that the people that we speak to understand, that these hospitals who are nonprofit are not going by their contract, and we're letting them get away with that. The contract is that they have to give back about as much as they are given the state in order to have a nonprofit status. And so that's part of what I wanted to say. But the other part of it has to do with you, Warren, because I'm wondering what you're thinking about in all this, and you're being very silent. So going back to Rick Stagenborg's and Hayden's discussion, and then on, there are several places where I think that I would like to hear your input in this discussion.
Was that directed to me?
Yes, yes. Specifically to you.
Well, I think I think some concepts that we're trying to play with here is, if we're concerned about investor-owned healthcare, that seems like not such a good idea. We're seeing problems with physician-owned, and I'm not sure I understand what all the issues of that are, but they seem to want to sell out for whatever reasons. So I think the thing that a term that I'm trying to use more is the third option is really patient-owned, and maybe that's kind of another word for publicly owned, but another way to think about it. If patients can own, for instance, I'm actually been talking about some people within the last 24 hours of what would it take to more or less raise some money and buy the clinic out in the name of the patients, the Corvallis Clinic, and keep it under local control. I think it would be there's a certain amount of interest. I mean, if people don't want to let United Care take over, well, there's options to that. I mean, there might be alternatives, and depending on how much public interest there might be, the amount of money actually might be less than you might think. I mean, to kind of make up the differential to keep the clinic independent. That's very preliminary kind of discussion, but it's the kind of thing I'm interested in right now. And actually, I would love to appeal to the clinic owners themselves and saying, yeah, that's one option. Would you be willing to consider other options? And some of the issues that the governing board is designed to do is to try to deal with this very situation. And unfortunately, in Corvallis, we're kind of coming on it kind of quickly before the state might be really ready. But to create more opportunities for local buyouts. I actually love it when Hayden says public utility district. I mean, something analogous to a public utility district. In Corvallis, we have Consumers Power, or Philomath, we have Consumers Power, and it is, it's basically provides power for a reasonable price, and there's a lot of things that it does very well, and I think that might be a good model for medicine. One of the things that concerns me is taking too much time here, but one of the things that concerns me in United or Optum's application is they say, oh, we're going to do all those wonderful things to standardize. We're going to mandate that patients take prescribed medicines that we think are right for them. Those things scare the hell out of me. The idea that United gets to make decisions for me is just, I think there's something wrong with that. And I'm, looking for ways to say, You know, how do we allow the patient to make decisions? Medicine is imperfect. Many times the breakthroughs of 10 years ago become the late night TV litigation ads of today. And, you know, to let some multinational corporation decide what medicines we should take is wrong. I think there needs to be more local and personal control. And I want to be careful here, but I say in circumstances where there's no like non-contagion. You know, if there's an epidemic, there's a public interest in making group decisions. But personally, let people make the decisions. Sorry, I took too long, but you asked.
No, very good.
So
Thank
I
you.
think we're Betty. I think you're up. Betty Keller.
Thank you. So I've popped into the chat. Thank you so much. This was actually a great talk. I'm so happy to hear this right now. Vermont's starting its legislative session, and there's a bill that PNHP of Vermont has asked a legislator to introduce, and it's just the short form, which I have limited experience, and I did not know what that was. And all it is a title, as a placeholder, so that there's nothing in the meat of it saying what's going to be in the bill. So I don't know how do you get co-sponsors if they don't know what they're actually signing up for. But he's got a few co-sponsors, and I've put in the chat a link to the document that I gave him when we were initially talking about what I would like in it. And then legal counsel said this is too complicated. Have your committee hash it out if you take it off the board and actually work on it. So my questions are: one, do you have model legislation that you recommend? And do you have any thoughts, like when you're looking at a bill, part of what they're thinking about is, do we have money to be able to actually do whatever this bill would require? And if we don't, if we're already looking at a tight budget and don't want to increase it, then we won't pass anything that's going to cost anything. And so like they're looking for ways to have an idea of how much it would cost to actually enforce it, for instance. So if you have some regulatory bodies that could do some of that, how much extra is this going to add to their cost?
Yeah. On the question of model legislation, I'm actually going to be working with NASHP, National Association of State Health Policy, something to develop model legislation for states. And that work's going to begin this month. So stay tuned for that, because they're hearing from a lot of states about interest in corporate practice of medicine. If you want to reach out, I'd be happy to talk to you and folks on your end, just to share what we have now.
That would be really super. Yeah.
Yeah. And then on the enforcement question, yeah, we're dealing with the same thing. There's this trade-off between whether it's going to have a fiscal impact or not. You know, with my academic hat on, I wish we could have stronger enforcement than probably we're going to end up with this session. But we're trying to get something done, and it's going to have to do that without a fiscal. You can't use sort of all the sort of enforcement levers that you'd probably like. So again, this gets down to kind of a political question, and there the money's always involved. But I think there is definitely a way to strengthen bans on corporate practice of medicine without a fiscal impact. So it's not nothing.
Thank you. I do have another question, but there are other people who haven't had a chance to ask yet. So I'll take my hand off and put it back up.
Thanks. That's Lou. You're up.
Okay, thank you very much. Don't forget, right? Profit is when you get more than what you gave, right? So let's keep that in mind. The question I have is more specific. I mean, I've been going through changes down here in Eugene with the closure of Peace Health Emergency in Eugene. And on top of it, Peace Health is not, so far in bargaining, not willing to pay home care nurses as much as they pay hospital nurses. Can you comment on that and where that comes from?
Oh, That's an
Hayden?
old racist policy.
It's racist?
Yeah,
Maybe.
because it was the African Americans and the other people who, when these things were being decided way back, they were the ones that were the home care workers.
Oh, these
And
are
it was
actually
crafted to
RNs. They're
keep them
actually
out.
nurses. They're actually nurses. So they're,
Yeah.
so is that like setting it up to contract it out? Or what's your opinion on this, Hayden?
Yeah, I think one explanation here, and I'm not an expert on this. The reimbursement is lower, so there's a big push to move patients out of the institutional facility. It's a complicated question because a lot of patients do want to be out of there.
Yeah.
From the perspective of corporate owners, it's cheaper. And particularly those that own both sides of the transaction. This gets back to what I was talking about earlier. You're the insurance company and the owner of the home care worker or home health agency. You really have an interest in having that patient not go to the SNF, and you really have an interest that patient getting home care and doing it with as cheap labor as possible. So I suspect that the source, though, of that is that the funding stream is different.
Okay.
There's the reimbursement.
You're cutting out.
Medicare is high for institutional care
Your
than home
signals,
care. But I know that the nurses unions, I think all of the country have been really involved, patient and
your signal's pretty wobbly a little bit, Hayden. So I don't know what you can do about it.
oh no.
That was good that we just heard you just then.
How about now?
Yeah, that sounds good.
All right, just tell me again if it goes out.
Okay, Chuck, you're up.
Thanks. A lot of people actually say, "What's up, Chuck?" Just Hayden, that was excellent discussion on acquisitions, and that was a grad level presentation. I have to say, grad school level presentation. A lot of folks are saying, can we get a sort of a simpler boiled down boilerplate version? So maybe, I don't know. I saw a lot of comments in the chat. Just wanted to share that. But on top of that, I just wanted to take advantage of the fact that we've got so many Oregonians who have done a brilliant job of getting your Democratic representative signed on with HR 6270. Give yourself a hand for that. You got all the D's on. Now we need to get, this is the state-based universal healthcare bill, Ro Khanna's bill. We need to get Republicans on board. This is really critical. And specifically, I know Sam's not here. Warren is here. Warren, if you want to say anything, you've already begun conversations with Representative Chavez DeRaymer and Cliff Bentz. And I just want to say that I'm here in Washington, D.C. I am your voice on the inside of the Capitol. And I just want to make sure that while folks are present, especially with so many Oregonians and other folks from around the country, this is going to be the critical tipping point win for us to get Republicans on board with this legislation. So I'll drop my contact information into the chat. I don't want to take much time here. I want to, be respectful of the conversation centered on acquisitions. But ultimately, the answer, of course, is getting single payer. And right now, our best prospect is getting it done at the state level. And so I think everybody here is tuned into what's happening. So please, I'll drop my information. I also dropped a link to an article that I wrote and recently posted on Op-Ed News. It's a thought piece. It's a think piece on strategy and how we need to really think about how we're going about this work. Again, I dropped the link in there. If you haven't seen it, I'll drop it again. Think about it. It really starts with the idea of visioning a success, like what the world we want and need. And how did we get there? We ask ourselves, how did we get there? How did we achieve this goal of state single payer, national single payer, healthcare justice for all, health justice for all? How did we do that? It's just getting us out of this sort of limited way that we do our politics in America. So I just want to kind of push myself and push you all as we lean into 2024 and look at it as an opportunity year and a year of radical hope and radical hospitality, radical love and solidarity. as we do this work together. So grateful for all of you. And Hayden, thank you ever so much for the work that you do. Look forward to connecting with you down the road. And again, let's get Republicans on board with this bill. Once we get one on, it's going to create a domino effect. So let's get Benson and Chavez de Remer. And since we name called you or name checked you again, Warren, you're welcome to say something. But Mike, thanks for running the meeting tonight. Thank you all. Let's get to work
Yes,
and get
sir.
a Republican on board.
If I just add just a couple of things to that. Republicans, particularly rural Republicans, are very aware of the failure of the existing system. And they're interested in concepts like universal care that can address healthcare without needing to raise the debt ceiling. And those are talking points that are useful to them. Thanks, Chuck.
Rich and Patty. Rich and Patty Wittrup, are you there? You are.
Hi. I'm Patty Wittrup from Corvallis. The first I heard about this was in the Lund report on January 2nd about the Corvallis Clinic being possibly purchased by Optum. And they, in that report, it said they were taking public comments on it until January 18th. That was on the 2nd of January. And to send it to the HCMO, which is the Healthcare Market Oversight part of the Oregon Health Authority, I think. Anyway, so I sent a letter today, but I want to know how much power, this is for Hayden, how much power does the Healthcare Market Oversight Group have in regards to purchases like this?
So in theory, they have the authority to block this transaction if they find that it's going to harm. I mean, it's a pretty catch-all phrase. I actually don't memorize the specific language of for the agency, but I think, you know, any finding around competitiveness or access or affordability or health equity, they could find basis to block the transaction. As I said, they haven't blocked any transactions yet. Probably the highest profile was, well, there've been a number of them, but one was Amazon. So we'll see. The authority, at least as of now, is there. As I mentioned earlier as well, the hospitals are challenging the constitutional basis of the entire agency, of the entire sub-agency of HCMO. But for now, the authority is there depending on what they find. They might do an analysis and say, this is the only option, and this is actually going to enhance access. That's certainly the argument that Optum is going to make. Again, that's the argument that's made for every one of these acquisitions.
Betty, you're up again.
Hey, Mike, can I just interject for 1 second? I'm
Sure,
so
Mary Beth.
sorry.
Yeah.
So I just wanted to draw attention to a couple of things I just popped in the chat, including the email to send to HCMO. Further up earlier, I just put the link to the Healthcare Market Oversight Committee. Very important that folks have their voices heard. You know, I have to say, and I may just be the eternal optimist, but this is a pretty new agency, and we are very grateful that that it's in existence, because it did recommend, you know, the health authority has recommended a no on the Scan Care Oregon merger. So the agency, as Hayden said, has the authority, but the most important thing is to hear from the public. And Patty, I mean, that timeline, I have yet, I'm sorry to say, had time to find out, like, what's the full length, right? I mean, I can't imagine when the first kind of notification of this was in early December, or mid-December. Mike, I'm sure you've got the date stamped on your brain, but that the public input part would be so truncated, right? Barely a month, if that, and during the holidays. So that's kind of an outrage in and of itself. So please grab that email in the chat. make sure you put Optum in the subject line and let people know that a simplified publicly funded healthcare system is better than the hostile takeover of healthcare.
Okay, Betty. Thanks, Mary Beth.
So thank you so much. I wanted to ask regarding the whole, like the nonprofit issues. Sitting here as a retired doctor and a a patient, mother of patients, etc., and a community member, it looked to me from the inside, but not looking at the books or anything. And it looks to me from the outside like we actually have a nonprofit hospital. Like the board is mostly community members. Like I don't know them all, but I don't know everybody in the town. And towns, surrounding towns too. And we're in a rural area. I mean, we're the county seat with 7,000 people. It seems like they're always struggling to find money. So the idea of there being like they can't really act like a for-profit in the perspective of trying to raise money for shareholders. They're trying to squeeze costs to stay afloat. And then the other, and so they are.
Betty, we have 3 people waiting. So truncate your question, please.
Okay, so the question is, it's a private nonprofit. Is there some set of criteria that you use that you could evaluate and make sure, like, how do I make sure that it's not doing this other stuff? Like when we write this bill, do we want to say that those kinds of hospitals shouldn't exist, that there shouldn't be private hospitals, and there shouldn't be private, mental health facilities if they're private nonprofits? Like, how do we decide if it's a good one or not?
Yeah, that's a fair question. What sounds like you're doing is actually digging in and looking at who's making the decisions at the nonprofit. And I don't speak for every single nonprofit hospital. I'm referring to sort of the larger, higher profile stories. For example, we've seen Providence is a huge health system that's nonprofit in the Northwest. And, there've been a slew of stories about, different sort of financial tactics they've played with low income patients to try to make money. I think in the rural setting, there's no doubt that rural hospitals are trying to stay afloat. And this again gets back to there are such structural financing issues that rural hospitals are really have a hard time staying afloat. And oftentimes they have to sell to a huge hospital system that's the only one there to provide them the capital to exist. So again, it gets back to the themes here of actually getting upstream and reforming the financing model to where and this gets back to sort of the utility model, which says that irrespective of how profitable it is, a rural community deserves to have a hospital. And the way the system's set up right now is not that way. So you're seeing rural hospitals, it's been happening for decades. Now it's happening particularly in maternity centers, are just shutting down because given the way that Medicare and Medicaid reimburses, given the way that they're paid on a per patient basis, like all these reasons create the system to where they have to try to make money because at the end of the day, we don't have a resilient healthcare infrastructure that's funded. And then we get all these downstream corporate actors coming in, figuring out ways to give them some capital. But then that leads to their control and a bunch of practices that I think a lot of us are sort of concerned about.
So we need to fit 3 questions into 7 minutes. Go ahead, Kay.
I think I'm a short one. I live in Corvallis. I've been with the clinic for over 45 years, so I'm concerned. And I could be totally off base with this, but it seems to me that if a corporation, an insurance corporation, is in charge of a health facility, that it would be to their advantage, pun intended, to require patients to switch from Medicare to their Advantage program, like the clinic recently encouraged all of the patients to do to stay afloat. And I'm just curious whether that's a big possibility.
Yeah, I mean, this is something, this is another one of the concerns of this vertical consolidation. This is something you hear anecdotally quite a bit. You pointed on, again, all these incentives are quite intuitive. So if you're a practice if you're an insurance company that's getting in the business of owning providers, you have a really strong incentive to acquire local physician practices. And then you can decide to essentially flip patients by contracting exclusively with your sister subsidiary. So as the provider and the insurance company. And then if I'm a patient who wants to continue to see the doctor, the only way to do that might be to join the Medicare Advantage plan. So again, I mean, these companies are in it to make money. Like this is all, it's business. So all these acquisitions make sense once you put it all together, because they're there to, to try to get more patients in their MA plan. I mean, we all know, like, they'll say this. So this is one of the competitive harms that we'd be concerned about. There's actually just a lawsuit filed in California against Optum for this very practice, alleging that they basically tried to use their sister subsidiaries to flip patients. So it's hard to get a lot of systematic data on this, but you hear sort of anecdotally these sort of things happening.
So John Santa, maybe from California now, right?
Yeah, I'm visiting California, but I'm an Oregonian. I wanted to emphasize in the HICMO program, the first thing they can do is require that the participants undergo a comprehensive review. Realize that when some of us objected to the Care Oregon scan merger a year ago, HICMO said comprehensive review, and that has taken a year. Delay is like kryptonite to these for-profit folks. They want to do something tomorrow. So for God's sakes, if you're worried about the Corvallis Clinic, follow Mary Beth's advice and send your sense of things to HICMO and urge that a comprehensive review be done. Within that comprehensive review, HICMO can require a community review board be set up, a community review board. They have actually done that for the Albertson-Kroger merger. None of us have paid attention to that because it's for pharmacies. But there's a community review board that's looking at that in detail. And you all in Corvallis and in the Mid-Valley should insist, urge, cry out that a community review board be created so that the Corvallis community can have input into this. We don't know why the Corvallis Clinic is doing this. It may well be that they've mismanaged their finances. It may well be that a subset of the physicians are retiring, and this is an advantage to make hundreds of thousands of dollars. We don't know that. So yes, HICMO could reject it or approve it, but there are some really key things kind of in between that they can do. And so I urge you, especially if you're from Mid-Valley, especially if you're Corvallis patients, speak up. Thanks.
Thank you, John, from your vacation. Hey, Bruce. Final question. You're muted still.
Thank you, John, for that. It's good to hear you're getting some vacation time. We've been busy at the Oregon Health Policy Board meeting this morning. And I would just like to read to you from part of my oral testimony. And this is for everyone else to consider what John was talking about. Your voice does make a difference. With these considerations in mind, perhaps Governor Kotek and OHA will look deeper into what is actually happening on the ground in a community impacted by such a staggering loss of medical providers as has occurred in Lane County. Evaluating an electronic application where much of the critical information is redacted and withheld from the public seems superficial and makes a sham of public input. A deeper dive by OHA evaluating the impact on patients in Lane County, coupled with a public document that discloses their findings, would greatly improve transparency. Until such document can be made available, a pause in the approval of consolidations of medical group with corporations similar to Optum's business model seems not unreasonable.
Great. Well, we're right on the hour. We want to thank Hayden for being here and a wonderful presentation, and for everybody else's input. Before you go, I want to put a link in the chat to keep these programs coming from one payer states, and also to help us lobby for the bills we need, both at the federal level and at the state level. So please take a look at that, and either sign on to the one payer states listserv, donate, volunteer. We need you. So before we go, again, a thank you to Hayden, and I bet you don't even have to go shoot hoops right now, because this has been a confirmation of your value, even besides basketball.
I appreciate that. Thanks everybody for having me.
Thank you.
That's great. Thank you. All right. Okay.
Enjoy your dinner, everybody.
All right. Thank you, everybody. Good evening.
Good to see you, Wes.
Thank you, Mike. Good to see you.
Yeah. Don McCann. Oh, thanks for joining us. Another person from California, former president of PNHP. And Stefan Ramdor from Florida. Eileen from Corvallis.
Yes. Hi. Nice seeing you, Mike.
Yeah. And Joe posing as Lois. Oh, there's Don. Hi, Don.
Glad to be here. Enjoyed the presentation.
Good, good. Thanks for being here.
I was glad that Mary Beth was sitting in on this meeting.
Yep. Yep. That was great. Aaron, where's your home?
Can you hear me?
Yeah. Uh-huh.
Okay. I live in Corvallis, and I was a nurse at the Corvallis Clinic until May, and I was in primary care for the last 11 years, and they're selling because it just doesn't pencil anymore. I feel terrible. Like, the primary care providers work so hard. A lot of the work we did was based on what insurance companies were requiring us to do, but there's more and more that is expected of these providers in shorter amounts of time. We couldn't retain staff. The turnover was very high, and that's because Samaritan offered a couple dollars more to medical assistants per hour, and their benefits were better, and the clinic tried so hard to stay independent. I feel terrible for the providers. They've been withholding wage from their own pockets for more than a year, and they have lives and mortgages and families, and we all know how expensive it is to live in Corvallis, and it's not what they wanted, and I feel terrible for them.
Thanks for that inside view. I think many of us feel that too, and hope that with some of the suggestions that Warren has made, that we can provide an alternative that in the long run, maybe even in the short run, will be better for the clinic as well as all the patients.
I'm sure what Optum is buying for the clinic for is going to be more than what residents of Corvallis could afford.
Mm-hmm.
But then you would still have to work with insurers, and the insurers are the hard part, and Medicare reimbursement continues to go down, and patients expect more, and there's less time, and patients are more complex, and pharmaceuticals reps are coming. It's just too complicated.
I agree. That's why it's happening so often. We want to be the outlier and find a way to save the clinic, keep the providers here. It's a treasure. The clinic is a treasure, a necessity for our area, and we cannot let it go to Wall Street. We've got to find another way.
I hope there is another way.